depending on where you're calling in to us today. Welcome to today's webinar from NCRC, the National Community Reinvestment Coalition. My name is Karen Colley, and we are happy to have you here with us today. The webinar that you are joining us for today is called Healthy Communities, Partnering with Hospitals to Invest in Community Development. So a little bit about NCRC, who may not be too familiar with our work. Here at NCRC, we are a coalition-based organization working with grassroots member organizations to create opportunities to build wealth. We work with community leaders, policymakers, and financial institutions to champion fairness in banking, housing, and business. And if you would like to learn more, we certainly hope you do, please check out our website at ncrc.org. And before we get into the content, a quick plug for an event that we're hosting in just a few weeks in Ohio. It's called the Reinvest Ohio Summit. NCRC from time to time hosts a number of local summits, and this year we're pleased to be in Ohio, again on September 23rd, Columbus, Ohio, for a full day of networking, information sharing, and making connections. In addition to sessions around community health and investment in fighting the opioid epidemic, we'll have content and experts sharing information, resources, and promising practices around opportunity zones, enhancing bank and community partnerships, land banks and job training, and much, much more, all focused on the state of Ohio. So if you are from Ohio, calling us today from Ohio, please register via our site. We would love to see you there. And it is never too early to start planning your professional development in 2020. So looking ahead, NCRC's annual conference is happening on April 27th through April 29th here in Washington, D.C. The Just Economy Conference is the national event for community, policy, government, and business leaders who work for fairness in lending, housing, and business. We offer, as we do every year, a wide range of sessions on community organizing, advocacy, housing, and more, including healthy communities. We also have our annual Hill Day, which is a major event for NCRC members and others to meet with and discuss issues with their representatives. And you can learn more at our site, again, ncrc.org. And housekeeping, brief note here before we officially get started. Today's webinar will end at 3:30 p.m. Eastern Time. We will have a question and answer session at the end of all presentations. During the presentation, if you have any questions, feel free to jot them down in the Q&A pod. You'll see that in the bottom right hand of your screen. In that pod, you should be able to type a question and then press enter, and we'll be able to see that. The webinar is being recorded, and the recording will be available at a later date. Anyone who has registered for the webinar will receive the link when the recording is available. And at the end of today's webinar, you will be automatically directed to a survey that we're doing regarding your experience and interest in the intersection of community and health equity. So please indeed stay till the end of the webinar and complete that survey. And now, let's get to the fun part of this webinar and introduce our presenters for the webinar today. That's me, Karen, and it's weird to introduce yourself, so I won't, but I will say that I am super, super lucky that I get to work with a lot of really amazing NCRC members who are thoughtful and motivated and collaborative, and they are all across the country doing amazing things, making great communities happen every day. I lead our Special Initiatives program here at NCRC, focused on aging in community, healthy communities, and age-friendly banking. And I welcome the opportunity to talk further with any members out there in ways that they can be involved in some of these initiatives with us, or folks out there who are not NCRC members who would be interested in learning more. Our second presenter today is Jen Jones. Jen is the Chief of Membership and Policy here at NCRC. With more than 20 years of experience in policy and development. Prior to joining NCRC in 2017, Jen served in the Obama administration as a senior policy advisor to Secretary Castro at the Department of Housing and Urban Development. Jen was charged with leading HUD's affirmatively furthering fair housing, neighborhood and community revitalization, rental assistance transformation, criminal justice reform, and socioeconomic mobility priorities for Secretary Castro. Prior to working for HUD, Jen spent more than 12 years at several nonprofit organizations and consulting firms specializing in a range of social justice causes, including LGBTQ equality, reproductive health, and global human rights. And our third presenter for today, who we're pleased to have join us, is Leslie Graham. Leslie is the President and Chief Executive Officer of the Primary Care Coalition, which is located in Montgomery County, Maryland. The Primary Care Coalition is a not-for-profit founded in 1993 with a mission to improve the health of vulnerable individuals and families by building partnerships and strengthening systems. In her role as CEO, Leslie was a founder of Nexus Montgomery, a partnership among 6 local hospitals in Montgomery County, nonprofits and county government to promote health and manage the total cost of care for the shared community. Prior to joining Primary Care Coalition as the Chief Operating Officer, in 2010, Leslie served as the COO and Vice President of Clinical Services for Planned Parenthood of Maryland. There she opened new clinic locations and built a multicultural workforce welcoming the communities in which services were delivered. Earlier, Leslie served as the Vice President of Health Systems for Maximus, a large consulting company where she started their international practice working with health systems in the Middle East and Latin America. We are excited to have our presenters here with us today. So why this webinar? So there's growing consensus that one zip code is the most significant determinant of health throughout the life course. A person's health is determined by more than just their individual lifestyle or their genetic makeup. It's influenced by where and how they live. It's the conditions of the zip code where they reside that tends to be the most significant determinant of their health over a lifetime. And that's certainly been something that's been voiced by NCRC members and practitioners convened in our Healthy Communities Community of Practice that NCRC has led over the years. So over the course of this webinar, we're going to discuss the role that hospitals can have as anchor institutions in communities to participate and make that impact within community. We're going to highlight successful examples of people and institutions that are collaborating with these health institutions. And finally, we'll offer some suggestions on how community members can get involved to partner with hospital systems in their own community. We're going to begin by explaining what a healthy community is and how we can create such communities. Then we'll look at what role the Affordable Care Act plays and how hospitals invest in their local communities. After that, we'll get a bit more specific with a comparison of the Community Benefits Agreement process that many of you may be familiar with, and goals and ways in which the community health needs assessment that hospitals and health systems engage in may be analogous and how they differ from one another. And finally, we'll examine how we can collaborate with hospitals to partner with their local communities to address the social determinants of health and make strides in positively impacting community health. Overall, the U.S. economy loses about $309 billion each year because of the direct and indirect costs stemming from health disparities. And I believe this particular statistic comes from 2015 or 2016. So the main determinants of health disparities are social determinants. Again, the prevailing underlying assumption in public health is that the health and wellness of a person is influenced by so much more than simply their personal lifestyle choices or their genetic makeup. Socioeconomic factors have a significant influence on health outcomes. And this can affect things like when and how often someone is able to access appropriate medical help, whether they have the access to needed social supports, how safe they feel while walking and living in their neighborhood, access to quality jobs and education as well, for example. Children are an especially vulnerable population because they can be exposed to adverse childhood experiences such as food scarcity, lack of housing, inadequate child care, or unsafe housing conditions. And these experiences, of course, leave imprints that affect other aspects of their lives, such as their education, and potentially impacting future educational attainment or job attainment. And of course, racial and economic segregation is prevalent. There's a growing wealth inequality. Studies project that health inequalities are only expected to increase over time as wealth inequality increases. A report by the Century Foundation found that the number of people living in high poverty areas has nearly doubled between 2000 to 2015. That's rising from about 7.2 million to 13.8 million. And there's also been a lot of recent discussion in the news around the mortality rates of African American women compared to white women, with African American women having significantly higher mortality rates at younger ages than white women. And the same can be said of maternal mortality among Black and white mothers. And healthypeople.gov, by the way, is a great resource for more information on this. So this chart is actually one that I'm borrowing from Democracy Collaborative, and it's a great visual chart. Here you see the dominant determinants of health disparities, or social determinants. What do we mean by social determinants of health? And so here we're referring to the economic and social conditions of communities in which people are born, where they live, where they work and play and age, and that impacts a wide range of health, functioning, and quality of life outcomes and risks. These conditions include patterns of social engagement and a sense of safety and security in a community. Resources like safe and affordable housing, access to quality education, public safety, availability of healthy foods, local health services, and an environment free from life-threatening toxins, for example, can have a significant impact on public health outcomes. So here we see the Department of Health and Human Services and the CDC, the Centers for Disease Control, cite that about 40% of factors that contribute to someone leading a long and healthy life are social and economic. And just 10 to 20% of what creates a healthy community is related to access to care and the quality of services received. So the takeaway from this chart is that the biggest factor in determining a person's health is their social environment and their socioeconomic status. So here we see a variety of items that fall under the social determinants of health, some of which we've already cited and others that we have not, like language and access to mass media. And the important thing here to note is that many of these factors are interwoven and related. So for NCRC, residential segregation, concentrated poverty, and access to economic opportunity are prime concerns within this framework. So our goal, and the goal of many communities, is to make positive impacts on social determinants of health and create a healthy community for everyone who lives, works, plays, and ages in a community. So for us, a healthy community is one that is proactive, prepared, and committed to equity. And defining that a little bit further, NCRC's definition of a healthy community is one where all members can thrive mentally, socially, and physically, where community organizations and members work together to strategically promote wellness, reduce chronic illness, improve physical and social environments, and expand community resources for all community members to reach their potential. Essentially, we envision community where people work together to address the various problems in the community pertaining to the social determinants of health, and by addressing these issues, such as substandard housing and racial disparities, we can enhance the physical, mental, and social well-being of everyone in that community.
Great. So thanks, Karen. This is Jen Jones, the Chief of Membership and Policy for NCRC. So we're going to pivot here. I mean, I think Karen's done a wonderful job of giving us a good sort of baseline about how we define sort of a healthy community. And NCRC has had sort of this healthy communities community of practice for a while. But when I came here in 2017, you know, I saw the work of NCRC in terms of how we sort of partner with or work with financial institutions using sort of CRA and leveraging CRA to deploy sort of additional credit and capital in underserved areas. And I said, you know, there's lots of other anchors out there. I mean, anchors, it's a broad group, whether it's a healthcare system or a financial institution or municipal government, our sort of community organizations, local businesses, philanthropy. All of them have sort of a responsibility to actually sort of give back and provide some level of community benefit. And so, you know, we started having internal conversations here about how do we start to leverage what we've been able to do as NCRC with our members and our partners around community benefit and bring that same model to other anchors. And the obvious choice for us was really looking at sort of healthcare systems in that regard. So the slide that you see is just a sort of representation of all of the sort of major sort of anchor systems in a community, right? And, luckily there's a growing number of anchors that are looking beyond, especially in the healthcare field, looking beyond sort of clinical interventions and pursuing other sort of upstream interventions to get at sort of health disparities in communities, right? NCRC has been involved in sort of conversations in multiple cities, where we've convened sort of financial institutions or partners, along with healthcare systems, municipal leaders, philanthropy, and community development practitioners, looking at ways that we can leverage resources in sort of low and moderate income neighborhoods around community development, because that's the sweet spot for us. And so, I could walk through sort of all of the different ways each of these stakeholders play a significant part. If I look at sort of local government, obviously they're involved in allocating funds both on the community health side and the community development side to address issues of community well-being. Most of you, if you are familiar with NCRC, you are very familiar with the Community Reinvestment Act and the requirement that banks or financial institutions actually invest in low and moderate income neighborhoods or provide credit to low and moderate income borrowers. Clearly sort of housing developers, they're sort of building housing, so it's about access to safe and affordable housing resources. Philanthropy, most foundations many foundations are actually funding or targeting social and economic or environmental factors that impact upstream and which lead to sort of health inequality. And so it's clear that, this is a fairly sort of robust ecosystem, but we need all of these players sort of working together and engaging in community if we're going to sort of come close to addressing the various issues that fall under social determinants. Hospitals. Hospitals, since the late 60s, they've been obligated to invest in community. This has always been a part of their mandate, so this is not new. I mean, I think this conversation was elevated once we had the passage of the Affordable Care Act, but nonprofit hospitals have always had a requirement or a responsibility to provide some kind of charitable community benefit, right? And it's taken sort of many different forms over the years, and it's been refined over the years. I think initially the focus was primarily on charity care, which, basically is emergent care. That sort of shifted and this, sort of leads us into a little bit into the next slide, but that shifted in the 2000s, and so we started talking about sort of, or post-1969, started talking about a community benefit, right? Hospitals have to provide a community benefit. The issue here is that there's never been sort of a clear sort of standard or definition of what or how sort of community benefit is defined. And so hospitals have often sort of defined and measured sort of community benefit in their own way. It was not until the passage of the Affordable Care Act that you saw some additional sort of requirements associated with sort of deeper community engagement through sort of conducting a needs assessment. It was not, you saw the requirement around sort of providing a certain level of financial assistance, a requirement that you actually sort of make publicly available sort of community health implementation sort of plans, which are connected to what's come out of a community health needs assessment, and that you in some way sort of engage community, but again, it's not sort of prescriptive, right? So hospitals have a fair amount, even today, even under the Affordable Care Act, have a fair amount of latitude in not only how they sort of conduct engage community in sort of assessing need, but also how they build out sort of a broader plan around sort of addressing those needs through community benefit strategies. So I covered a lot sort of in that area. If you go to slide, I would say 17, there's a little more detail here, but it does sort of break down sort of the evolution of the community benefit standard, right? So, so some progress has been made, but there's still a tremendous amount of work to be done, especially as it relates to, sort of what NCRC and its members sort of think about what community benefit strategies are in the community development space, right? There's lots of stories out there around sort of hospitals that are starting to sort of dip a toe into investing in sort of affordable housing, thinking about sort of supplier chain and procurement, thinking about sort of their own hiring practices and how they can create sort of workforce development strategies that support and lift up sort of low and moderate income communities. But it's not a large number, but we are sort of seeing that evolution and hospitals starting to see the importance of doing that work. Some of it is just sort of the nature of how the conversation around the responsibility of anchors and their mission has evolved. And some of it, to be completely candid, is related to the ballooning sort of cost of healthcare, right? And sort of hospitals, nonprofit hospitals, and states thinking about sort of what can be done or what needs to be done to try to contain those costs. So we can go to slide 18 is good. So these are the sort of current requirements under ACA for nonprofit hospitals. Sort of the Affordable Care Act didn't sort of include sort of a minimum or a threshold around community benefits. It just said you have to provide one. A growing trend has been states sort of taking sort of matters into their own hands, right? I mean, states have lingering questions about how can we make sure that nonprofit hospitals are sort of maximizing sort of the tax benefit they receive. And so you've got states around the country that are pursuing sort of state legislation to try to create thresholds for nonprofit hospitals. It's a couple of examples. Just this past June in Oregon, the governor signed a bill that, state regulators will assign each hospital a mandatory community benefit spending floor every 2 years based on factors like the hospital's financial position, how much money they have, and workforce and community demographics. So, I mean, these are states sort of saying we want to see sort of nonprofit hospitals step up. Right now, on average, I think hospitals are investing, roughly 12 or 13% in sort of community benefit strategies. And a good chunk of that actually is still in that sort of emergent care or charity care bucket. And so, states like Oregon, California, Colorado are looking at ways to not only sort of create a minimum threshold for those nonprofit hospitals, but also in some cases like Colorado, sort of define or require a more robust sort of community engagement strategy around their needs assessment, right? Though nonprofit hospitals are required to conduct a community health needs assessment every 3 years, what that looks like varies from institution to institution. And many hospitals are still sort of in some cases hiring sort of third-party consultants to sort of cull data that they already have and are doing a bare minimum of stakeholder engagement and sort of really meeting the community and having conversations about what the needs truly are. So on slide 19, we define sort of the various pieces of a community benefit. Obviously, we are certainly focused on a number of these, but our bucket is that community building bucket, which is where a lot of the hospitals aren't typically investing most of their community benefit dollars in the community building bucket, and that's something that we want to try to change. And so, that's been sort of our focus over the last, I'd say, year and a half is really trying to engage both our network and the community partners in a discussion around ways in which we can engage with sort of hospitals or healthcare institutions in a conversation, not only through the needs assessment process, but also in sort of being a partner in some of the sort of solutions or interventions that are designed to meet the need. All right, so what's the role of the community health needs assessments? I talked about this a little bit. There's community members that I've met with around issues like this that, they will constantly say to me sort of nothing about us without us. And so, NCRC has always been around sort of how do we make sure that community members play a frontline role in sort of shaping, whether it's with a healthcare institution or a financial institution, shaping sort of the sort of solutions designed for their community and their neighborhood. So it's around community engagement, identifying and assessing community health needs, and then planning for impact. We've had a number of conversations with, our network and members across the country around how do we do this a little bit better. In some ways, there's webinars about that. I mean, most of our members know us as the organization that primarily is focused on banks. And so we're trying to sort of do some level of sharing information that we have, getting information from our network and members across the country to figure out what you've identified as a need in your community, who the sort of healthcare players are, and the ways in which we can partner together to see if we can get those hospitals to actually invest more in community development strategies. Next slide. So community benefits agreements versus sort of the health needs assessment, right? For those of you that know NCRC well and have been through sort of a CBA process, you can see the similarities between the two. For us, it's about sort of sitting down with whoever the anchor is, bringing in sort of community leaders representing, on the CBA side, representing sort of mortgage, small business, philanthropy, community development, and really sort of negotiating an agreement that really does sort of address the needs that have been expressed by those community stakeholders. The other piece of it that I think is actually sort of unique in the way sort of NCRC does its work around CBAs is that, we always want to make sure that there is some level of greater accountability of that institution. And so it's not just, getting a community benefits agreement in place, but it's also creating an accountability measure through reporting and through creating sort of an advisory body that is made up of community leaders within that institution's footprint to oversee that agreement for the life of the agreement. So that's sort of how we work on the CBA side. If you look at sort of a community health needs assessment, obviously you've got, your anchor, you've got public health leaders, but you've also, again, have community voices at the table. There's a requirement around sort of reporting annually on the Form 990 to the IRS. There clearly are federal, state, and local requirements. It's every 3 years, which most of our community benefits agreements are anywhere from 3 to 5 years. And then there are sort of penalties for not sort of meeting the requirements of the community health needs assessment. I will say, though, unlike the regulators that oversee banks and that are sort of hold the banks accountable for their sort of CRA work, the IRS is not the toughest or tightest regulator, I think, of nonprofit hospitals, and so to sort of the most that I've seen, I mean, I think since ACA was passed, I think there's only been one, maybe two nonprofit hospitals that have lost their accreditation, and in both cases it's because they actually refuse to actually conduct a needs assessment at all. For the most part, if you are sort of meeting the baseline requirements, the IRS will sort of approve your, it's not even an approval process, you can maintain or retain your tax-exempt status. So that's 21. So how hospitals determine how community investment funds will be spent. So, this is what the process, in a lot of ways, should look like, right? So, there should be on a part of the anchor, there should be some identification of community leaders. Hospitals have tons of data and access to tons of data, as do sort of community leaders, but it really is sort of sitting down and having discussion around that need. And that's, that's the step that I think is happening in some cases, but not widespread. That data gets rolled up, and the community is involved in sort of helping and that community institution sort of prioritize sort of what their priorities will be within their community health implementation plan. The community is involved every step of the way. And there's still some feedback loop between sort of that healthcare institution and the community stakeholders that have been involved around sort of ultimately what's not only sort of externalized in the need assessment, but also sort of how that feeds into the broader implementation plan.
Thanks, Jen. And before we delve into Leslie Graham's presentation from Primary Care Coalition, I just wanted to take a moment to remind folks that we do have a question and answer pod on the right-hand side of your screen. So if you do have any questions, feel free to go ahead and insert them there. You can also download the PowerPoint presentation via the download pod, which is just above the Q&A pod on your screen. And then for a brief sort of mention for folks that I think joined after the webinar officially began, we will be, when we close the webinar room, everyone will be automatically directed to a survey, and we hope that you'll be able to take that survey for us today. Leslie, it's your stage.
My stage. Well, thank you.
Thank you.
Hi. You're welcome. Hi, everybody. I'm Leslie Graham. I'm the president and CEO of the Primary Care Coalition, and also happen to be a founder and board member on a hospital regional partnership, which is one reason why I'm talking to you today. So I'm going to take you through just a couple of things. First of all, I wanted to make sure that we get to what you all want to hear. So I'm going to talk to you today about a collaboration that we've built between hospitals and community-based organizations, and how we have managed that collaborative decision-making when there are multiple organizations of different sizes and strengths and interests, and then also how we talk about money, in other words, savings, and how those accrue to different portions of the partnership, because that's important. Everybody, ultimately, people want to know about the money. So we're going to talk about that today. First, I'm just going to tell you a little bit about Primary Care Coalition. So we've been around for about 26 years. Our role, we're an interesting organization. Our role is really to build partnerships and strengthen systems of care. And by care, I mean medical care, bringing together social determinants of health, so social services, other things. So we don't really do direct service delivery ourselves, though we are a not-for-profit, but our job is to work with other nonprofits and bring people together into coalitions and partnerships. So that's what we do. We are what some people might call a backbone organization, though I think we existed long before that term came about. We are located just outside of Washington, D.C., and that's an interesting area. We're a highly diverse area. We largely work across two counties, Montgomery County and Prince George's County. A highly diverse area. About a third of all the residents are foreign-born. If you go to the school systems, they'll tell you they deal with about 180 different languages, so very diverse area. It's also a place with growing wealth disparity. So take Montgomery County. It was for many, many years in the top 10 wealthiest counties in the nation. It has dropped dropped out of that top 10 list, although it still remains fairly high up, but we have growing poverty within the county itself. And it's a large area. There's about 1 million people in Montgomery County, about 1.1 million, about 1 million also in Prince George's County together. So our job as PCC, as Primary Care Coalition, we put together networks of various types of providers, medical, social service providers. We find funding for service gaps in the community, whatever that gap is. Traditionally, the gap we have been looking to fill is health care for low-income individuals. So we've branched out in that quite a bit with social determinants in the last few years. We layer over that setting of measures and doing quality improvement with all of the partners that we work with to make sure that the programs that are being run are effective and good use of the funders' money. And I would say overall we serve about 30,000 people a year through the various programs, which are all done through partnership. And our focus is really on improving the health of various target populations. So when I say we serve this area, we also work with areas, we work with DC, with Virginia. We talk to people around the nation about what we do. So it's not, but this is the primary place that we've started and where we have done most of our work. So I'm going to talk to you about one specific partnership that PCC serves as the backbone for. It's called Nexus Montgomery. So what is Nexus Montgomery? It is a collaboration among the Montgomery County's 6 hospitals. So Montgomery County, as I said, it's about 1.3 million people when you look at the region that these hospitals serve. 6 hospitals, which represents 4 different health systems, and they have traditionally been competitor hospitals. However, in this case, Nexus Montgomery, they've come together to look at a way that they can promote health in the community, reduce hospital utilization, and manage total cost of care in ways that no single organization could achieve on its own. And that's important because that comes to the mission of this particular partnership, is to find that sweet spot and do what no single hospital organization could do on its own. We serve as a neutral entity, and we have picked multiple target populations that we would start working on. We did this, so the 3 that are examples are behavioral health. That was selected because we went to the hospitals and said, what are your pain points? And they said, those who come in with severe mental illness, they end up boarding in our emergency departments for days, weeks, months. Not a good therapeutic spot for that individual, nor is it good for the efficiency of the ED. Somebody has to be a bed sitter with the person, et cetera. So there's a lot of concern over those who had severe mental illness. We have, this particular region of the state of Maryland has about 46% of the uninsured in the entire state, even though we're only about 21% of the state's population. So the hospitals also spoke about the uninsured. They have a lot of uninsured patients. And then seniors, age 65 plus. In Maryland hospitals are under a different payment mechanism than the entire rest of the country, and they currently have some very significant penalties if Medicare patients are readmitting to the hospitals or utilizing hospitals for avoidable situations. So these happen to be examples of 3 out of their now 5 target populations, but these were 3 of the original populations that came about when we started this partnership with the hospitals. I do want to say that when I talk about this partnership, Nexus Montgomery, I want to be very clear, it is not a community benefit partnership. It is not tagged in the hospital's financials as a community benefit activity. It actually is money that we originally wrote with the hospitals to get some grant funding, and then over time that grant funding has shifted down and the hospital contribution has shifted up, so that now about 70% of the money is being contributed by the original grantor, which was the state of Maryland, and 30% is being contributed by the hospitals themselves. So I want to talk about some things that allowed us to form this collaborative. So these are 6 hospitals. As I said, they're 4 different health systems, all of which were competing health systems. And when I say competing, I do mean like for years they would be taking each other to court over who could build the next hospital or who could open the next certified heart area or whatever. So there's been a lot of antagonism among these hospitals. They really felt as though they owned their own patients. But we were able to use data to show that they actually shared their patients significantly. We showed that their patients, over 30% of any patient, if any patients that came in, between 30 and 56% of that patient load that was their patients would end up in another hospital within the year, not within their own system. So 30 to 50% of their patients were not really their patients, they were shared patients. We also took a look at this across all the community providers that the hospital felt were feeders into their hospital. Well, about the same level came out, which was only about 30% of a community medical provider's practice might end up at that hospital, and 70% would end up at some of the other hospitals. So they really could see that they did not own their client base, so to speak. So it was very important for us to have data that showed why they might want to work together as hospitals. We also were able to define a financial interest of the hospitals, in this case, that came together in the original collaborative. I'm going to talk a little bit later about all of the other organizations that are involved. But we were able to define that the hospitals had a financial interest in making changes outside of their hospitals. This was partly because of, as Jen talked about, the social determinants of health. They could see that they as hospitals had limited influence on the health of those who were ultimately coming to them, whoever those were, because now they know they don't own them exclusively. So by showing them the complexity of their patient population, that they shared it across the community, that social determinants were really impacting people coming into their hospital. So if they were trying to work on perhaps 30-day readmission programs to keep people out of the hospital, keep people from coming back to the hospital after they've been in the hospital, not that that's not a valuable program, but too late. You need to do preemptive programs up front. So that was a factor we were able to work on. And another thing we needed to work on was really defining with the partners what were acceptable timeframes to the hospitals. If you're going to work on something like diabetes prevention as opposed to chronic disease management, diabetes prevention is going to take 10 years to change the diabetes incident rate or longer in a community, for example, whereas chronic disease management might keep somebody from getting to the hospital the next day. So what is it that the hospital wanted to work on? What time frame did they want their result? So I think that was another very important thing to work on. In terms of the social determinants of health, one of the things that we recognized when working with the hospitals are built to control things. It's a wonderful thing inside of a hospital. You want to have infection control. You want to make sure that your surgical theater is well controlled. So control is something that is built into hospitals, and people who tend to work there are very good at creating order. So it was really an experience for them to want to work with community-based organizations and not just want to build it themselves. So it was very important to us to have them recognize that working with community-based organizations was going to be the way to impact their mission and financial interests around shared populations and not just build their own programs. So we did that by looking at, we got the hospitals together and said, what are your shared, now that you understand that you share patients, what are your shared pain points, or what are your shared populations? So shared pain points were things like in state of Maryland, hospitals actually get penalties if they don't reduce their potentially avoidable readmissions by a certain amount. So that's a monetary pain point for them. And as I said, there were certain populations like those with behavioral health, severe mental illness, diagnoses, where those were populations that were a pain point for the hospital. It was causing internal efficiency issues for the hospitals themselves, as well as they recognized not providing the best therapeutic care. So we had to find commonalities. The other thing that we found as commonalities were places where the hospitals were trying to do many-to-many relationships. For instance, every hospital was trying to work with the skilled nursing facilities to which they discharge their patients to make the process work better and not have patients bounce back into the hospitals. So every hospital was trying to go to maybe 15 or 20 skilled nursing facilities, but another hospital was also going to a subset of those because they also discharged to those. So could we find places where it made sense for the hospitals to work as one solid group of 6 hospitals with a set of skilled nursing facilities all together where they could have a many-to-many relationship? So that we were able to find sweet spots like that made sense to come together as collaboration among 6 hospitals and other community providers, whether that's social service or medical providers, that benefited all. Then we had to, of course, get the hospitals to commit to not reinventing the wheel, commit to not building it themselves, and value what was already in the community, leveraging the community assets that were already there. So that was largely introducing the hospitals to who was in the community and the expertise that that particular community-based organization would bring. For instance, with regards to the behavioral health population, we introduced them to a organization that had been in the community for over 100 years doing social service and behavioral health work. And we built trust. You have to build the muscle of trust with those who are coming into the partnership. And then they were willing to work with that organization to develop community capacity. So just as examples, I want to give some concrete examples. So using behavioral health as an example, the hospitals, which were experiencing a pain point with those with severe mental illness, we were able to partner them with a local behavioral health provider that runs crisis houses. In other words, crisis houses where people who are suffering a behavioral health crisis can be admitted there for a few days to be stabilized instead of going into a hospital, instead of going through the emergency department to a local hospital. And so the hospitals actually invested in building a crisis house. They gave this community-based provider the down payment on a house and the initial startup operating costs so that the provider could get this up and running. And this now pays back to the hospitals for years to come because hundreds of bed days will now go to those crisis house beds instead of going into a hospital ED. And the community provider benefited because they already ran 2 crisis houses that were running at 99% occupancy with wait lists. Now they've got another one which they couldn't afford to open or take the risk to open because they didn't have that initial startup funding. So that's an example of how it was a win-win for everybody, but we had to bring it together and show that it was going to work. And I gave the example before of sort of how the hospitals coming together, the skilled nursing facilities, the same. We were able to bring the 6 hospitals together to say, yes, we will work with, in our case, there's 37 skilled nursing facilities that largely serve these 6 hospitals together, some at different levels. Some might only see 5% of the hospital's patients, but none of them have a majority of one hospital's patients, so it made sense to all work together. So we brought them together, and now we run a learning collaborative where they can learn from each other, and we got the hospitals to buy the skilled nursing facilities data so that they could see what their quality was, and so the hospitals paid for them to have quality, paid for them to have quality improvement consultants come in via us as the backbone to help the skilled nursing facilities understand how to improve their quality and improve their ability to keep patients there in the skilled nursing facility and not bounce them back to the hospital. So those were the types of, some of the things that we have done. Another one, as an example, is wellness and independence for seniors at home. We took 42 different senior living apartment complexes, all, you know, they may be from local housing opportunity commission, or they may be subsidized, or they may be market level, but we took those and we built out a health coaching model that all hospitals pay for, but no one hospital could have done that themselves. So now these health coaches go into these 42 different buildings where about 7,000 people live in total and work to determine who is going through some either social changes, familial changes, monetary changes, health changes, who might be at risk for their health declining, and then get them the services that they need so that their health does not decline and they can be stabilized and remain independent in their home. So those are examples of some of the programs that we have started through this collaborative. Just to give you an example, we spend over $7 million a year in this collaborative through various programs. So it's not a small undertaking. And then, but of course the hospitals, for that $7+ million every year, they want to know whether they're getting any return on their investment with these community partners that we've brought together in this collaborative. So we have determined some ways of developing ROI, but I think it's important to talk through, because if you're looking at making partnerships with hospitals, these are some of the things to think about. One is, what level of impact does your program make? Are you trying to measure your impact only on those who were enrolled in the program, or are you trying to measure the impact of your program on all those who could have been enrolled? In other words, sort of a target population or an intention to enroll. Some people might not have enrolled because they were they declined the program, or they weren't offered the program or something. But usually the people you end up giving the program to is a slightly smaller, or sometimes largely smaller group than those you would like to have or targeted. So knowing the differentiation there, and then also looking at the impact this makes on the full community. So we have looked closely at all of our programs as to how we measure each of those different impacts. You need to know what impact you're making on your program actual participants, because that's a way you can measure whether your program did what it was supposed to do. You know, did we make an impact on person X with their diabetes, say? So you can see whether your program makes an impact. But if it's making an impact on people, are you making an impact at a large enough scale on those that would be useful to treat in that program, or to give that intervention to on a program target population basis? So you have to look at that as well. And then for the hospitals, they also want to know whether they are making an impact on the full community, especially in the case of our collaborative, because it is 6 different hospitals in a shared community. We cannot accrue the return back to any individual hospital, so they need to know that the entire population is benefiting in some way. So this can be hard to define these things, but requires effort and requires understanding where you're going to get the data from, like from where can you acquire the data that will tell you these things, and then do you have the data analytics, and do you have the data use agreements or the data sharing agreements in place to be able to do this. This took us quite a long time, over a year, to get the data sharing agreements in place between some community providers, the hospitals, and a state health information exchange in order to be able to do the kind of ROI analysis that we do now. So don't expect to be able to set it up very quickly, but it can be done. And then you have to look at who benefits from the costs. So what is the cost of the program? How do you define what a savings is? Is a savings just a savings to the hospital? Are you going to go wide and say we're going to look at savings on, say, the educational system or the criminal justice system? Or are you going to look at, we're going to look at savings across the entire healthcare continuum rather than just hospital savings? So define what you mean by savings, and then define what part of that savings would accrue to any one partner in the partnership. In our case, hospitals, even if you were to do a program that takes 100 patients out of the hospital that year, they don't accrue that full savings because it's not like they could close down a ward or get rid of a whole shift of nurses or something like that. That's not going to be a way that they can have savings. They can only do a stepwise savings. So you have to look at what is reasonable of the perhaps total amount of money you think you're saving, what could really accrue to that individual partner, and then figure out what the return on investment is there. Often this is hard to do because you have to prove a counterfactual. You have to prove what didn't happen. Look, we saved you 100 patients who didn't come in through your ED. Okay, but so you have to figure out what your counterfactual is to prove that. And then, of course, we talked about the data sharing. In our case, we have developed a very robust governance structure for this hospital partnership with the community organizations. So we have a board of managers that is made up of the hospital people, and it makes the decisions because the hospitals are the funders, or all the money, even though the hospitals really contribute about 30% of their own money, but they got the grant for the other 70% from the state. So the hospitals are responsible for that money, so they form the board of managers, and then they contract with us, PCC, to have all of the staffing that is full-time day-to-day staffing that runs and oversees all of these programs, and does the data analytics support, and we do the governance support, so we help the board get their agendas together and do all the meetings and all the stuff that it takes to get things done behind the scenes. As I said, we do the data analytics. We keep the budget for the pooled budgeting for all the pooled programs that we are running. And then we create the contracts and the alignment with all of the community-based providers in our region. So whether that is the behavioral health provider or whether that is the contractor who is running the nonprofit that is running the Wellness and Independence for Seniors at Home program. So because the hospitals are not implementing these programs themselves, and we wanted them to have the expertise of existing community-based nonprofits, CBOs, who were doing the work in the community already, we stepped in the middle between the hospitals and those community-based organizations in order to draw them together, and we actually oversee. We don't do the work ourselves for these programs. We contract with the expertise in the community, and then we oversee that and report back to the board. One reason for that is that hospitals often have a lot of size, and in negotiating, and they have legal teams and all these other things that often smaller community-based providers don't have, and so you get a disconnect in the negotiation of what this piece of work is going to look like and what a contract is going to look like that can overwhelm the community-based organization. So we step in the middle and make sure that the contracting and the running of the program by the community-based organization can be done on a scale and level that they are very comfortable with, while we also meet the needs of the board of managers to report back to them on what is happening. So just in summary, so what I would say is that a successful partnership with hospitals, and in our case among hospitals, has to address some potential barriers, and you have to have strategies to address these. So in our case, one of them, as I talked about, it's sort of governance. How do you make sure who's going to have voting rights for governing how funds are spent? We spent a year getting consensus on the formal governance structure and the operating rules. This partnership is just coming to the end of its third year of actual operation, but we spent a year starting it up, defining all of how it would be governed, who would have input, who could vote on how budgets were decided or what programs would be implemented next. The next thing was ensuring that the hospitals really understood that this would be delivered at the grassroots level. The CBOs were going to be delivering the actual programs themselves. We found it useful ourselves as PCC to be sort of that management, that neutral management partner between the CBOs and the hospitals, deciding on what the speed of results are that we want. That was really important. Otherwise, you get partway through and the hospitals are saying, we're giving you money, how come we don't have any results yet, or how come we aren't getting an ROI? So determining whether your portfolio of programs are going to have all short-term or long-term or mid-term results in them, figuring out how you're going to get the data and agreeing to the data sharing rules, very important, and then addressing this sort of imbalance of power, imbalance of resources and capacity to take on risks that is different between, say, a large hospital system and a community-based provider. And then looking at the partnership life cycle, we found that it was easiest to focus at first on some programs for which the hospital still retained a lot more control and had short-term results, while slowly building up these longer-term or fully run by community partner programs. And that found it was very important that we did that while constantly not forgetting that we had to talk about the soft stuff as well, like how do we become a team and trust each other as different organizations and the people who are now coming together to meet, since we're all from different organizations, building that collective faith in the partnership itself and in each other so that we can make more difficult decisions about budgeting and move things to longer-term ROI. And that then broadens it to what we can do. We're now looking at other programs that are much more long-term and health equity focused, and it has taken us about 3 years to get there. So that's it. I just wanted to turn it over back to you, Karen.
Great. Thank you, Leslie. That's a great segue. So on our end, how can we go about talking, how can we go about developing relationships with hospital leadership to be able to convey the benefits of upstream investment and then engage in collaborative discussions like we see here with Primary Care Coalition? And Leslie touched a bit on this as well. So hospital financial officers and the financial committee team are conventional investors, not necessarily used to investing in community development, although that is changing as more and more leaders become more aware and invested in making an impact on social determinants. I was actually talking with someone from a hospital system earlier this week, and they were basically saying that they were essentially acting as consultants to a couple of different health systems around social determinants. So there's definitely a wave of change coming. So understanding the return of investment for a hospital or a health system is a prime motivator for upstream investments. And so while best practices, I think, in metrics and measurements on providing that data is improving, as you heard Leslie said, it took them, their coalition, a full year to be able to sort of figure out and agree to what those metrics would be. It's definitely a challenge, and there are a number of resources to get started with evaluating the return on investment. One resource that I recommend is the Commonwealth Fund. There's a short tool on their site that's specifically aimed at community health stakeholders, health systems, and community-based organizations. It's worth taking a look at. But in terms of sort of making that business case, CDCs bring financial knowledge to hospitals and can certainly help leverage other resources. They bring those established relationships, long-term community relationships, and both of these benefits can act as incentives for hospitals to invest in local communities. So in continuing to build the business case, hospitals and health systems have a mission-driven focus on reducing health disparities. They tend to be the natural community development partners because their mission is already aligned or analogous to that of community development partners. And for those anchors that do not have a mission that values an explicit reduction of health disparities in partnership with the community, that's where advocates may need to build a strong business case and strengthen relationships with those entities, which of course is something that builds over time and can can take a significant amount of time to get to that point. The benefits to hospitals are twofold in the sense that by investing in a community, they're able to reduce the amount of people who require medical assistance as a byproduct of societal and socioeconomic factors. As Leslie mentioned, one of the major challenges that a number of the hospitals faced was readmissions. So hospitals then benefit from financial and community development expertise and capacity brought from the CDCs.
Great. So thanks, Karen. So next steps. I think you heard sort of a wonderful example of, how this work can happen from Leslie. I talked a little bit about NCRC's sort of initial approach around sort of organizing in community around this work, looking at health equity, sort of broadening sort of the anchor institutions that we're working with. To some extent, it's our engagement with our network and our members. It's the way that we sort of identify some of the hospitals who are or could be sort of natural sort of partners for a relationship like this, right? Typically the way NCRC works is we leverage in the banking world, sort of mergers and acquisitions, right? So that is information that is publicly available when a bank is acquiring or merging with another bank. And it's clear that there will be some impact to sort of low and moderate income communities within their service areas. It's a perfect opportunity for us, and they're statutorily required to sort of engage in a conversation with community stakeholders who might be impacted by this event to talk about the ways in which that institution can ensure that sort of service delivery is just as strong as it had been before those entities either came together. And so, sort of looking at sort of who the hospitals are sort of in a community, thinking about sort of, where there are sort of leverage points or opportunities for engagement is one thing. Understanding which hospitals, could be, doing more to bring sort of a broader sort of array of community benefits to sort of stakeholders is one thing. We have started working with our existing sort of coalition structure to start building out sort of a mechanism by which those coalitions can start sort of thinking about sort of the hospitals that we can sit down with as a sort of NCRC coalition around sort of social determinants and health equity in these communities and neighborhoods. You heard sort of Leslie talk a lot about sort of trust, right? And every single conversation that I've had or convening that we've had where we've brought together a diverse array of stakeholders around sort of social determinants, the sort of common thread through all of them has been sort of sort of building sort of trust between sort of the community development sort of world, the sort of local leadership, philanthropy, and sort of the healthcare system about sort of how can we work together. I mean, I've had more conversations than I care to admit with healthcare institutions to say, we certainly want to provide a community benefit, but we don't feel like we have a clear understanding of sort of what is the ROI and who can we partner with, because we're not housers. We're not, we weren't built necessarily in our minds to sort of lead sort of workforce development strategies or to sort of deal with issues of, criminal justice reform, right? Typically those that are sort of dipping a toe in the waters are thinking about sort of, food insecurity. They're thinking about sort of issues of mental health and trauma. They're thinking about substance abuse. All of them have sort of a common thread that you can sort of make an easier case around sort of the health benefit. But once you start to push them at things that feel much more sort of community development in scope, it's where they get nervous and antsy. But bringing sort of strong sort of community development practitioners and partners to the table to sort of partner with them on something like this is really the way to start to move the needle a little bit. But we have to build over time, and Leslie said it takes time to build that level of comfort and trust. In some ways, the initial conversations often start with sort of acknowledging and recognizing what is sort of shared ownership in sort of meeting the sort of health needs of a community. And sometimes that is more difficult when you're talking to, like, let's say, a bank that feels like, you know, sort of my focus is this. Am I really, do I have sort of some responsibility to also meet this other need? You know, for us, it's about sort of bringing all the necessary anchors together and leveraging their economic assets towards this goal. So, and then, you know, we've talked a little bit about strategy development, and then thinking about sort of TA and technical assistance, not only for sort of those in the community development space, which, you know, sort of may need it, but also in some ways for the healthcare institutions who are sort of moving into sort of realms that they are unaccustomed to. So,
thanks, Jen. So before we wrap up, some thoughts on where we can go and what we can do from here. So for those who are interested in learning a little bit more about what your local landscape looks like in terms of your own healthcare provider or the hospitals and health institutions in your community, communitybenefitinsight.org is a great tool to utilize. It's an excellent tool. I encourage you to take a look and plug in your own hospitals and health systems in your area so you can see the types of investments that they have been making or not been making in your community. And then think about ways that you may be able to advocate at the local, state, or federal level for a more anchor-oriented mission for hospitals. One of the things that we're following here at NCRC is the Social Determinants Accelerator Act. It was introduced this summer to Congress. The act essentially aims to set up a council and a program to address problems that may limit a population's ability to access health care. It has bipartisan support, and we don't have an official statement on it just yet as it was just recently introduced, but we are following it for sure. And just sort of briefly mentioning some other things, and you know, Leslie alluded to this as well, as did Jen, that partnering with hospitals or coalitions to bring about a more community-oriented type of engagement around health and healthy communities is a multi-year process that may begin with small kinds of engagement, but ideally that relationship grows toward deeper collaboration. And so be prepared for that level of multi-year type of engagement that may be necessary to get to that type of deep relationship. And then as Leslie mentioned as well, evaluation and metrics go a very, very, very long way, and it's, I think, incredibly challenging. Like you heard, Leslie took a year to reach consensus among the metrics used, but it can be challenging to get to that sort of specificity and depth of illustrating that direct correlation, right, between addressing social determinants of health and improved health within your community. Challenging, but certainly not impossible. And then lastly, technical assistance on how to better engage in local community health, and hopefully that's a strong point for us here at NCRC. Growing capacity of your coalition, building power, and the ability to engage in the steps that ultimately lead to significant investment from anchor institutions is a process for sure, and I think that this is a good opportunity to point out that we, here at NCRC, we do offer technical assistance and research assistance to NCRC members, and we're happy to talk further with members about how we can be of service to you. And that is just the resources page, which is a good time to reiterate that you can indeed download this presentation if you'd like in the download pod. And now we're going to get to the fun part, which is the Q&A portion. And I will go ahead and remind folks that if you'd like to submit a question, feel free to go ahead and do so in the Q&A pod on the bottom right-hand corner of your screen. I've just got a couple of questions for you, Leslie, and Jen may have some as well, but one of the things that you mentioned was, the shared pain point for the hospitals that are part of the Nexus Montgomery Coalition, and I think the first thing you mentioned was avoidable readmissions. But then I think at the end of your presentation, you talked about the return on investment and how the way that it's maybe packaged or provided to the hospitals is very much sort of calculated overall, I guess. So that makes me, so my question is, how do the hospitals know that they are specifically making a dent in that avoidable readmissions when the return on investment is calculated so broadly? And is that something that's maybe another pain point for them, or is that something that is just sort of part of the process that they accept?
There might be two answers to that. So one answer is that Maryland is unique in the United States in how it pays hospitals, and the hospitals are on what's called a global budget. So it's different than a sort of fully just fee-for-service way that it is everywhere else. So in Maryland, hospitals are specifically incentivized with penalties and rewards around hospital readmissions, but also they are about to be also incentivized and penalized around total cost of care. So they actually get members of the community attributed to them in various ways, complex calculations, and so they now have a sort of responsibility of fiscal interest in what the cost of care is along the care continuum, even if the hospital cost portion of that may be small. So it is an incentive that is particular to Maryland, although other areas have some things that are somewhat similar.
Thanks, Leslie. So we have a question coming to us from Michelle. A couple questions here. How did this idea for collaboration start? What was the time invested to launch this collaboration, and how do you fund your work to support the collaboration? Which I think you answered a couple pieces here and there, but can you talk a little bit about the time invested in terms of the launch?
Yes, so it started with an idea of wanting to do a place-based initiative for seniors. So no money involved. It was just an idea that said, let's do something for seniors, those who are living independently. We are a congested urban area, or urban, suburban, but large area, so travel time is difficult. So we said, let's do place-based initiative for seniors. Let's try something out. Let's design something. It started as just an idea for a design of one program. So we started designing that, and as we were designing that, we realized that it really would affect multiple hospitals had an interest in the seniors, the Medicare seniors who were in these buildings. So that's sort of, it started as an idea for a program, and then a funding source came along, a grant came out that would allow us to do that. So we applied for the grant. Then we got the grant to really design and test and pilot this program. While doing that, money came out for this idea of what we call regional partnerships, where you could bring hospitals together, and hospitals could jointly implement programs and get money from the state of Maryland to do that. So it started with a great idea for something to do in the community, and that was started with hospitals. That idea was with hospitals, how do we help, how do we work with seniors who are in independent living to ensure, to preemptively improve their health, and therefore reduce avoidable readmissions, or avoidable admissions in that case, not readmissions. So it started as an idea for a program, then some funding became available, then larger funding became available. So that's how it worked.
Great, thanks, Leslie. So our next question comes from Steve, and his question is, are there any examples where, on the same project or initiative, a bank and nonprofit hospital worked together and the bank got credit on their CRA exam and a nonprofit hospital counted the activity as a community benefit?
Well, that
might be a good question for you.
Yeah, I'm like, are you a banker, Steve? And so I think there are some examples. One that comes to mind is Ohio-based, and I think related to sort of ProMedica and some work that they're doing. I know that KeyBank was one of the financial partners or investors in that project. It's my understanding in talking to Key that, they were, pretty sure that they would get some level of, because they clearly checked with their regulator prior to, credit in terms of their CRA exam, and it was around sort of affordable housing development. And I believe that the healthcare institution also could count it as a community benefit. I mean, the funny thing is that in this particular case, it is, sort of financial institutions do get antsy, but they are often in a position where if it's clearly, tangibly a sort of community development benefit for low and moderate income borrowers or in a low and moderate income like census tract, they know that they will get credit. I mean, they'll double check just to make sure since the partner is another anchor institution. But it's been our experience for the few that have taken that step that they've been able to get sort of CRA credit for it. For me, it's a little rare, I think, on the community benefit side of whether or not those healthcare institutions are actually allowed to sort of count that as and get, in some ways, quote unquote, credit, if you will, as that kind of investment as a part of their sort of community benefit spend. So I hope that sort of answers the question.
Thanks, Jen. So our next question comes from Anne. Her question is, what financial institutions participated in the Nexus Montgomery project, and what was their role?
So in the case of Nexus Montgomery, there is not a financial institution participating. It is hospitals, community-based organizations, and a portion of the funding comes from the state of Maryland itself.
Great. I think that might be all the questions we have that came in that I think we can answer. Well, there is one question from Catherine. Did you have to persuade the participating hospitals to collaborate? I think you may have answered this a bit in your presentation, Leslie. But did all hospitals sort of come to the table sort of in the same vein, or was there a little bit of give and take for one or two of the participants?
For sure, it was not sort of that we placed a call and everybody said, absolutely, sign us up. No, that's not how it worked at all. You always need a champion, and so there was, as I said, we brought data to the table that was able to show that to the hospitals themselves that they had more shared patient populations than they knew at that time. And so that was important, and that had them then think to themselves, should we do this? We then, the hospital CEOs got together and discussed it, and it was not something where they said absolutely yes immediately. It took a couple of conversations and probably a few weeks or maybe even 6 or 8 weeks for them to come to a yes that they wanted to go forth. But I say that in this case there was also state money on the table. So it was also a decision of whether they should go alone or go together for some of this state money. And so not only could we bring the data saying you've got shared population, but there was an incentive to say we're probably going to, this region can probably get the money from the state better if we go together as a group of hospitals. And these hospitals all have mission, these are all very mission-driven hospitals who do care deeply about these communities.
Thanks, Leslie. Can you say a little bit about the type of data sharing that needed to happen between the hospitals and how that's sort of handled? I mean, my understanding is that that's data that is not sort of easily handed over to anyone, but you've got so many hospitals who are obviously competitors, but then also have this shared interest. How did they, or do they handle the data sharing process?
In the case of Nexus Montgomery, Primary Care Coalition is the neutral data analytics entity, and we happen to have expertise in that, and so we can serve as an agent of each hospital to get the data that each hospital would be able to get on their own for themselves. We can aggregate it, do the analytics, and then hand back to all the aggregated information and results that they need. So that way no one needs to necessarily see each other's data, but we can see the overall results.
Great, thank you. It looks like we have one additional question from Philip. His question is, can hospitals invest in creating affordable housing on land they own, primarily to serve lower-wage hospital employees or to create housing for homeless or very low-income people? And I think the answer is yes. They certainly can.
Yeah, the short of that is yes. And for the hospitals that I've had at least some conversation with, especially if they're dipping a toe in the sort of affordable housing space, I've heard of them sort of dipping a toe in that water by sort of developing housing for their employees, right? So on campus to make it easier for their employees to be closer to the hospital, closer to where they work. But yes, the short answer is all sorts of yes. They absolutely can. And yes, I mean, I think they would still receive some kind of, I would think, some kind of community benefit associated with, creating that benefit for their own employees in the community. I think they could count it as a community benefit strategy. So, we didn't talk about this much, but I mean, as it relates to land, obviously it's our major anchors that own most of the land. If we think about sort of affordable housing development, whether it's, our hospitals or academic institutions, our banks, they own a lot of the available land for redevelopment. And so, as we, continue to talk about how we engage anchors in this sort of, again, what I refer to as sort of shared ownership in providing a community benefit and addressing both issues of, sort of health disparities, but also generally around, other sort of issues around sort of poverty. It's looking for those kinds of opportunities to partner and work together to sort of meet that need is essential. And, I would say it's where sort of our, community stakeholders and partners can be sort of very impactful in sort of helping sort of initiate a conversation around sort of the opportunities those anchors have to really sort of have a deeper impact. So.
Great. Thank you, Jen. Well, I don't see any further questions, and we are approaching the 3:30 p.m. mark. So I'm going to go ahead and say thank you all so much. Thank you, Jen. Thank you, Leslie, for joining us today. Thank you very much. I want to remind everyone that there is a survey that we're hopeful that you'll be able to take. As soon as I close out this webinar room, you'll be automatically directed to the online survey, and it's got a couple questions in there around your own sort of experience at the local level around this intersection between health and community development. So I think it would be really helpful if you're able to take that survey. And then a good opportunity also just to say for NCRC members out there, if you're interested in learning more about this intersection, talking with us more about it, please feel free to reach out. You know where and how to find us. And so with that, I'll say thank you again to everyone for participating, and we will see you on our next webinar. Thanks a lot.
Thanks, everyone.